Assalamu alaikum. First of all, I want to thank the scientific and organizing committee. I want to thank Prof. Ghada Al-Khatib, Prof. Ghada Al-Saghir, and Prof. Khalid. Uh, this is actually is not easy subject. Okay, yeah, and it seems from the topic that it is easy. Actually, not. Take this case: is a 40-year-old female. She's a teacher, and known case of Hashimoto's thyroiditis with hypothyroidism 1 year ago, and thyroxine 100 microgram per oral once daily, TSH 3.8, free T4 1.1 picogram per ml, total T3 81. Usually in hypothyroidism we don't measure total T3 or free T3. Actually, we usually measure TSH and free T4. This patient complained of persistent fatigue, weight gain, lack of concentration. So what do you suggest for this patient? TSH 3.8. You will continue current thyroxine dose. You will increase current L-thyroxine dose, or you will add liothyronine or T3 to thyroxine, or you replace thyroxine with T3, or you replace thyroxine with thyroid extract. So anybody from the junior, I am not asking senior, I learn from them. So if any junior want to do, choose one. Okay, because of the time, we are limited with the time, we increase thyroxine because TSH 3.8 in the upper limit of normal. If we consider the normal 0.4 to 4 in the upper, so we try to keep it in the lower side of the normal range. This is the patient again, thyroxine increased to 125 microgram per day, TSH now 0.8, free T4 1.1, T3 81. The patient still complain of persistent fatigue, weight gain, and lack of concentration. So there is no improvement in the symptoms. Some investigation done to rule out secondary causes like anemia, renal failure, for example, vitamin D, LFT, you do cortisol, vitamin B12 sometimes cause symptoms that, okay, misguided as hypothyroidism. So what you will suggest now? Continue thyroxine, increase thyroxine, add T3 to T4, or replace thyroxine with T3, or replace thyroxine with thyroid extract. Okay, because of the time, we'll add liothyronine or T3 to T4. So potential risk and benefit should be discussed if you want to start the patient in combination therapy. Okay, some recommend reduction of the thyroxine dose. Okay, so in this case, reduced from 125 to 100. And Satimil or T3, this is available in Saudi Arabia. Combination desiccated is not available and not recommended. Actually, what is recommended is separate. You add T3 if you want to give these patients. Or Satimil is available there, but more expensive. 4 months back, TSH 0.6, free T4 1.1, total T3 140, patient tiredness improved. Patient lost 3 kilogram and memory and mood improved. This is a subclinical hypothyroidism. Subclinical hypothyroidism, TSH from 4 to 10, offered usually more than 10. So what can cause persistent thyroid symptom despite normal TSH? Many causes. Dr. Halal already talked, around 10 to 15% of the patient still they have symptom while they are on thyroxine, like fatigue in 80% of the cases, weight gain in 70% of the cases, memory disturbance, or mood changes. Possible explanation: non-thyroidal illness, other autoimmune disease like adrenal insufficiency, for example, maybe LT4 not adequate like our patient, or maybe autoimmune neuroinflammation. We know that Hashimoto's thyroiditis is an autoimmune disease, so maybe the thyroid function is normal and the patient still have symptom, and this is related to the autoimmune process, not related to thyroid function. Or maybe low tissue T3, or maybe need for combination, or other reason we don't know. So this is maybe the possible reason. So first of all, look for other causes. For example, rule out diabetes, adrenal insufficiency, rule out anemia, rule out chronic kidney disease, vitamin B12, vitamin D deficiency, hypercalcemia. Look for drugs. Statin can cause myalgia, can cause some symptoms. Beta blocker sometimes can cause depression. Look for the lifestyle of the patient in the work at the home. Look for an obese, look for obstructive sleep apnea. So look for other potential causes. So usually we do this: alcohol, drugs, very important, depression and anxiety. You do simple investigation like CBC, ESR, ferritin, vitamin D3, vitamin B12, sometimes celiac disease or adrenal insufficiency. Most of the patient treated with T4, actually they have subclinical hypothyroidism. So TSH from 6.8 to 7.9. Actually, they don't have a frank hypothyroidism. And we know from studies that the effect of a treatment in subclinical hypothyroidism is not actually, they don't have improvement in the quality of life of symptom. So the patient should understand. If the patient in thyroxine dose less than 1.2 microgram per kg, suspect that the patient has already subclinical hypothyroidism. This is the thyroxine dose, should be lean body weight. This is another way to calculate the thyroxine dose. This is depend in the TSH level. You can calculate it. I think the best to calculate the dose according to the body mass index. If less than 25 normal, you start 1.6. If 25 to 29, 1.47 from 30. So in obese, you don't use the 1.6 microgram per kilogram per day. Use lower dose. So if the body mass index above 30, we start by 1.4 microgram per kg. This is interesting study, but we don't apply it. They compare patient Hashimoto's disease. Sometimes you find patient with Hashimoto's disease and the patient asks you, I want to do operation. They did study. They look for patient with Hashimoto's thyroiditis and they are on thyroxine and they don't improve. Say they did for them, divide them in two groups. One group, they did total thyroidectomy for them. They are Hashimoto's disease. And the other, they continue in thyroxine only. They found that the quality of life and fatigue improved after total thyroidectomy. This is strange. This is maybe related to the autoimmune process. They found that the anti-thyroid peroxidase antibodies reduced from more than 2,000 to 152. So the symptoms may be not related to thyroid function, related to the autoimmune disease. Very important surgery, very difficult in patients with Hashimoto's disease. Actually, they have lymphocyte infiltrate, they have fibrosis, so very difficult surgery. Thyroid hormone, 80% secreted by the thyroid, 20% of the T3 secreted by the thyroid. The most important source for T3 is deiodinase conversion of T4 to T3 in the brain and the peripheral tissue. So the most important, 80% of the T3 in the brain come from type 2 deiodinase. This is the deiodinase. D1 is in the liver and the kidney, and D2 in the brain. This is convert T4. We know that T4 is a prohormone to T3. T3 is the active hormone actually. They found some polymorphism, okay, for the deiodinase 2 can explain the response. We know that deiodinase 2 convert T4 to T3. This is the most important. So in this study, retrospective study, they look for what? They look for patient with polymorphism or a change in the deiodinase 2 enzyme. Okay, they found that ALA homozygous presence is 16%. They found that those people, they have polymorphism to deiodinase 2, they have worse outcome and they have better response to combination therapy. But unfortunately, this study was not reproducible. They go again to another study in 2017. They found there is no difference in response to combination therapy with patients with polymorphism compared to those polymorphism. So polymorphism cannot explain, okay, this improvement. The other thing, there is no correlation between serum T3 and the response to combination therapy. Maybe T3 is low and the serum you measure it and the response is low. So we know that thyroxine or thyroid disease is the second commonest endocrine disease after diabetes. This is levothyroxine monotherapy is the standard care, okay, for therapy because low cost, more stable. If you compare T4 to T3, the half-life of T4 is more. Usually to adjust the dose you need 6 to 8 weeks. T3 shorter half-life, so you have rough and peaks, tough or okay, maybe cause tachycardia and tremors. This is different study. I will not go detail and very busy slide, but this is red doesn't show improvement with combination therapy. This is in the blue showed some improvement. This is another study also in the red color or the red arrow doesn't show improvement, okay, to the combination therapy. Most trial performed comparing T3 to T4 combination therapy to monotherapy doesn't show difference in the outcome, but actually the patient, they prefer T4 to T3 combination. So the patient prefer, but the reason why, we don't know actually. It is not related to the mood or behavioral quality of the life. In some patient, they respond because of the polymorphism. Some patient doesn't show response. Some patient improve in T4 and T3. And if you meet them after 6 months, they have relapse. So this is maybe placebo effect. So why there is no improvement? Main explanation, most of the study, they have few patients, only 3 studies, more than 100. Trial is heterogeneous, different combination ratio, different causes of hypothyroidism like post-thyroidectomy, different study design. RCT comparing combination therapy did not specifically recruit patients with attention to persistent hypothyroid symptom. It is possible that those individuals most likely to benefit from combination maybe not have been included in trial in sufficient number. Sometimes if they don't have sufficient number. Look here, if you look here to the left, in the upper left, if you start T3, there is almost 40% increase of the serum level of T3. So this can cause tachycardia, can cause tremor. What's about the recommendation? The recommendation of American Thyroid Association, there is no consistent strong evidence of superiority of T3, T4, T3 combination over monotherapy. Recommend against routine use, but you can use it on a trial basis in the patient who remains symptomatic. The European Thyroid Association start with LT4 if for recovery not obtained, then try combination therapy as experimental treatment. This is how to use combination. It is better to use separate. We know there is what is called desiccated thyroid hormone or armor thyroid hormone. It is available in iHerb. Okay, a lot of medication, they use it actually. Maybe outside, 40% of the patients, they use combination therapy actually, as of label. As a physician, we don't use it. But if you want to use, better to use separate T3. So you reduce the dose of thyroxine. This is the recommendation. Some suggest that the cytomel dose or T3 dose just divide the total LT4 dose over 50 and split it to 2 doses because it is short acting. Avoid T3 in patient with cardiac disease. Aim to normalize the free T4, T3, and TSH. Take blood samples in the morning and try for 6 months and then see the response. Some they recommend the ratio 10 to 14, ratio of T4 to T3. So in summary, the vast majority of hypothyroid patients do well in thyroxine treatment alone. Persistent symptom despite normal TSH was reported by 10 to 15% of the cases. Very important to rule out secondary causes, as Dr. Muhammad Halawa said. Current clinical evidence is not sufficiently strong to support routine use of LT4 T3 combination in patients with hypothyroidism. If for recovery not obtained with LT4, then try T4 to T3 combination for 6 months. If there is a response, you can continue. And don't depend on T3 level to adjust the dose, because some they use pre-dose T3 level, some they use post-dose 3 level. This does not correlate with the symptoms. and we need more well-designed study to clarify the role of LT43 combination therapy. Thank you for your